Good morning, dear friends. I'm Dr. Shishir Agrawal, working in Apollo Medics Hospital, Lucknow. Thank you, AORA, for giving me this opportunity. Today, this topic is RV assessment in the series of Pocus assessment. So, when we usually do to the echo of a patient, we focus more upon left heart. We often ignore right heart. But for us, for anesthesiologist, right heart is very important. It is a cause of mortality in 50% of the patients, and it is directly affected by the anesthesia management, like fluid management, alveolar distension, means ventilation strategies, acidosis, hypercarbia, and hypoxia. So, as we see, RV is a basically very superficially located structure just behind the sternum. It is triangular in shape. When we see in transverse section, it is crescentic in shape and it is wrapped around the left ventricle. So it is very thin walled structure. It is divided in three parts: muscular inflow, trabeculated apex, and very smooth outflow. Inflow and outflow is divided by the infundibulum in two parts. So when we talk about functional anatomy, it is very thin walled structure and it can better respond to volume overload. The contraction of the right ventricle is basically longitudinal compared to the left ventricle. It moves, movement is just like a balloon. It moves from the base towards apex because inner wall fibers are longitudinally arranged and uh, outer it is circular arrangement of the muscular fiber. 30% of the contribution is from the either interventricular septum or the left ventricle. In right coronary, basically flow is in both the phase, in diastolic as well as in systolic, compared to the left ventricular where coronary flow is basically in the diastolic phase. So RV is designed to manage volume while the LV is to generate the pressure. Now we look for the causes of the right ventricular failure, and we can divide RV failure causes into three categories. One is the decreased RV contractility, RV volume overload, or RV pressure overload, like in situation like pulmonary embolism, pulmonary hypertension. But for us, these six causes are very important. The most common cause of RV failure is the LV failure, pulmonary hypertension, right ventricular infarction, fluid overload, tricuspid regurgitation, and in acute setting, it is pulmonary embolism. So, what are the windows required to assess the right ventricular functions? As we know, when the cursor of the probe is towards the right shoulder, we cut the heart in longitudinal plane. The RV is the most superficial structure. This is parasternal long axis view. And when we cut this into the short axis, it is parasternal short axis view, and we usually see this left ventricle and the right ventricle. But for RV assessment, we need an extended window, which is aortic valve view. So in this view, this is the left ventricle, this is Mercedes Benz like aortic valve, and all the three, like right atrium, right ventricle, and pulmonary artery, we can visualize in the single window. So this window is required to assess pulmonary artery acceleration time, RVOT diameter, functions of the tricuspid valve. Another window which is very important is the apical four chamber window. So left side it is left ventricle, left atrium. This side it is right ventricle and right atrium. But the catch is here, we need to focus more upon right ventricular free wall. So RV focus view is required to assess right ventricular functions. So if you are afraid of the mathematics like me, this eyeballing is sufficient for most of the anesthesiologists. So look for the normal heart. In normal heart, the apex is formed by the left ventricle, while there is no contribution of the right ventricular apex towards in the apical segment, in the apical zone, apical contractility. And see, this septum is interventricular septum is deviated towards the right side. Size of the LV is larger than the right ventricle. But see in this picture, it is RV failure. Here, apex is formed by the RV and the septum is going towards the left ventricle. And if we see the size, RV is bigger than the LV. So in the short axis view, you can appreciate during this stole, this septum is flattening or it is moving towards the left ventricle. Now coming to the qualitative assessment of the right ventricular size. Compared to uh, LV, RV is smaller. Normal ratio is 0.6. But if RV is dilated, or this ratio is more than 0.6, it means RV is dilated, and mild to moderate dilatation ratio is around 0.6 to 1. But if this RV is bigger than the LV, means ratio is 1.0, more than 1.0, it shows severe dilatation of the right ventricular chamber. Normally, apex is formed by the left ventricle. Interventricular septum flattening during systole is a indication of volume overload, while this flattening during systole as well as in diastole, it shows there is a pressure overload. Now, we see in most of the human being, slight tricuspid regurgitation is present, and the jet velocity or the uh, length of the jet, it is directly proportional to pulmonary hypertension or RV pressure. So see, when we put color, it is moving away from your echo probe. So it is TR jet. In next video, you can see this TR jet is almost approaching towards the superior wall of the right atrium. It shows severe pulmonary hypertension. Now coming to relatively difficult part, which is the measurement. So to measure the size of the right ventricle, we need an apical force chamber view with RV focus window. Size should be assessed in the end diastolic phase, and we should take the maximum diameter. Like just below the tricuspid valve, when we measure here, the size should be it should be less than 42 mm. In the mid segment, size should be less than 35 mm. And when we measure longitudinally from the apex to the wall, its length should not be more than 86 mm. If size is larger than this, it shows dilatation of the right ventricle chamber. Now coming to the RA dilatation or RA dimensions. So when we measure this length, basically RA is a cuboidal shape. When we measure this length, it is a major axis. Major axis should not be more than 53 mm, while the minor axis should not be more than 44 mm. And when we measure the area, it should not be more than 18 centimeter square. Now, RV wall thickness, which can be assessed in subcostal window. and this size should be measured only in the diastolic phase. If this thickness is more than 5 mm, it indicates right ventricular hypertrophy. Now the fractional area changes. So to measure fractional area changes, we need a apical 4-chamber view focusing towards right ventricle chamber. And both the phases are required, diastole as well as systolic phase. So in the diastolic phase, we freeze this window and we place our cursor from the endocardium. We trace endocardium excluding all the trabeculations up to the just below the annulus. And this area is measured. Similarly, this area is also measured in systolic phase, and the formula is fractional area changes is basically end diastolic area minus end systolic area divided by end diastolic area multiplied by 100. Fractional area changes if it is less than 35%, it shows poor RV function. So basically, fractional area change is not a ejection fraction. Fractional area change is basically it is an indicator of heart failure and it is directly related with the mortality of the patient. So you can see here in diastolic we have measured the area and in systolic we have measured the area, but in right side window you can see the fractional area changes is only 20%. It means it is failing right hard. Most of the time, we look for ejection fraction when we see the left ventricular contractility. But in case of right ventricular contractility, we cannot measure ejection fraction because this LVEF is basically based upon certain assumptions like LV is an elliptical structure. It is just like a bullet, but these assumptions they cannot put when we measure the RVEF because shape of RV is very irregular. It is just like crescenting sometimes more elliptoid. So we cannot measure ejection fraction of right side. So in that case, TAPSE is very important. TAPSE is basically tricuspid annular plane systolic excursion. It shows longitudinal contraction of the myocardium towards the apex. So apical 4-chamber view is obtained and cursor is placed towards the lateral annulus. And M mode is placed. So in M mode, we see the maximum excursion, which should be more than 17 mm. If it is less than 17 or 16 mm, it shows there is a poor contractility or poor functions of the right ventricle. Now, systolic pulmonary artery pressure. How can we measure pulmonary artery pressure? So, pulmonary artery pressure can be measured using TR jet velocity. Higher is the RV pressure, higher will be the TR jet velocity. So, based upon Bernoulli's principle, pressure can be measured using this formula, pressure equal to 4V squared. So, maximum jet velocity is measured, which is V. RVSP is basically this peak TR jet velocity, this pressure plus right atrium pressure. That atrium pressure we can measure using CVP or can be measured using IVC diameter. So basically, RVSP is equivalent to pulmonary artery systolic arterial pressure. Normal resting peak TR gradient should be more than 2.8 meter per it should be less than 2.8 meter per second. If this jet velocity is more than 2.8 or 2.9 meter per second, it shows higher PA pressure. When we convert this into the pressure, this pressure should be less than 35-36 millimeter of mercury. But if this pressure is more than 40 millimeter of mercury and patient is having symptoms of the dyspnea, it means something is wrong. We should further evaluate our patient. There is a risk of pulmonary hypertension or pulmonary thrombus in this patient. So in apical four-chamber view, we put the continuous wave Doppler, and this tracing is you will get this tracing, and this peak jet velocity should be measured. We should measure only this solid part. This speckles, these should be discarded. Only this solid part should be taken into account. How can we measure the atrial pressure? So cursor should be placed. We take this phase array probe, and the cursor of the phase array probe should be in cephalic direction, and we will get this window. And we measure IVC diameter 2 centimeter distal to the this junction of the IVC with the RA. And when this size is less than 1.5 centimeter and collapsibility is around 100%, it shows like this. It shows there is some dehydration. This patient needs more fluid and CP is around less than 5 millimeter of mercury. But when this size is around 1.5 to 2 centimeter and collapsibility is more than 50%, so that atrial pressure will be around 5 to 10 millimeter of mercury. When the diameter is more than 2 centimeter and collapsibility is present more than 50%, the right atrial pressure is between 10 to 15 millimeter of mercury. But when the size is more than 2 centimeter and there is hardly any collapsibility, or collapsibility is less than 50%, RA pressure is around 15 to 20 millimeter of mercury. Now coming to DP-DT ratio. So DP-DT means how much this myocardium can generate pressure over the fixed particular time. So it is an index of myocardial contractility. So we measure time required to achieve TR jet velocity from 1 meter per second to 2 meters per second. So around in this means during this period, pressure difference between 1 meter per second to the 2 meter per second is around 12 millimeter of mercury. So normal, this ratio is more than 400 millimeter mercury per second. But if this ratio means if this myocardium is not generating adequate pressure, it requires higher time to generate the pressure, means contractility is poor. So how can we measure here? In the previous image where we have placed the color Doppler through this tricuspid wall. So this time, in this scale, we measure this time, and again a cursor is placed around when this velocity is around 2 meter per second. So this is 1 meter per second velocity, and this is 2 meter per second. And time travel between this to this 1 meter to 2 meter per second, it is measured in this scale. This is time scale. So this is basically velocity scale, and this is time scale. So this time is measured. So we see this time. This time is in microseconds, basically in microseconds. So around 3 microseconds is required to generate this 12 millimeter of mercury pressure. So when we divide this by the time, we get DP-DT ratio. It should be normal is around 400 millimeter of mercury per second. Now relatively a complex but essential right ventricular index of myocardial performance, or T index. Basically, T index, it shows both systolic and diastolic dysfunction. So to measure T or RIMP, we require tissue TDI or tissue velocity of the lateral annulus. When we use basically this pulse wave Doppler is it measures higher velocity, like velocity of the red blood cells or the fluid. But to measure the velocity of the myocardium, a very low frequency and high amplitude waves are required. So T index is isovolumetric contraction plus isovolumetric relaxation divided by total ejection time, and T index should be less than 0.5 by tissue Doppler. So how we measure this T index? Apical force chamber view is required, and we put cursor on the lateral annulus, and after that we put the pulse Doppler. We on the pulse Doppler, tissue Doppler and pulse Doppler, both we. When your machine is not having this, your software is not updated and TDI is not available, we can use pulse wave with the lower scale and lower gain, because very low frequency is required. So now see this wave. When we put this tissue Doppler, we get this kind of curve. So here, first positive deflection is tricuspid valve closure. Okay, and now this is the tricuspid, and the last one is the tricuspid valve opening time. And between this is the ejection time when there is this S wave. So tricuspid valve closure, then there is isovolumetric contraction, and there is enough pressure to open the pulmonary valve. Now this pulmonary valve opens. After that, ejection phase is there. After ejecting the volume in the pulmonary artery, the pressure is decreased and it's come to around 0, and this pulmonary valve now closes. And this time, after this, pulmonary valve is closed as well as the tricuspid valve. So a negative. So this is the isovolume relaxation time. So then, after this relaxation, myocardium relaxes, and there is some negative pressure which opens the tricuspid valve. So we measure this time, IVCT, isovolumetric contraction time, plus IVRT, this isovolumetric relaxation time divided by ejection time. Means high time for isovolumetric contraction, it shows poor contractility, and if it takes high time in relaxation, it means poor diastolic function. So similarly, we can measure T score using only pulse wave method. Two different windows are required. So one through the tricuspid valve and another through the pulmonary valve. This is in the pulse wave is placed in the RVOT, and this will show this graph which will show the ejection time. And when we place this pulse wave through the tricuspid valve, the time between the two positive waves is tricuspid closure time. So T score is tricuspid valve closure time minus ejection time divided by total ejection time. So abnormal T score is if it is more than 0.4 by pulse wave Doppler. So same tracing is here. We measure the peak velocity. Peak S velocity, if it is less than 0.9 centimeter per second, it shows poor RV contractility. If this peak E dash velocity or E prime velocity is less than 0.8 centimeter per second, it shows poor relaxation of the right ventricle. If this second negative velocity, A dash velocity, if it is less than 7 centimeter per second, it shows poor relaxation. So, like in the Vexus score, we measure the backflow. Backflow in the IVC, backflow in the pulmonary vein, in the hepatic vein, and the renal vein. But if it is Vexus score is high, or if there is a congestion, different kind of tracing we will get. But this is not part of this lecture. This will be covered in a separate talk. Now, what are the features of pulmonary embolism, acute pulmonary embolism? If RV and diastolic diameter is more than 30 mm, or ratio of RV and LV is more than 0.9, and there is a if there is hypokinesia of RV is present, it shows pulmonary embolism. If peak TR velocity is more than 2.5 meter per second, it shows pulmonary hypertension, which in acute setting is suggestive of pulmonary embolism. And McConnell signs, it is very peculiar of pulmonary embolism. In McConnell signs, basically there is RV free wall, impairment of the RV free wall, but contractility of the apex is preserved. So in this video, you can appreciate the contractility of the apex is preserved while this free RV wall is hardly contracting. So what we should do when we get poor right ventricular function. So most important is treat the cause of the RV dysfunction. But after treating the cause, we can divide management in three parts: preload optimization, afterload optimization, and management of RV contractility. So in preload optimization, if there is RV infection or pulmonary embolism or features of hypovolemia, 300 ml of fluid should be given with the idea to optimize CVP of 8 to 12 centimeter of water. If there are features of hypervolemia, like if IVC is distended or Vexus score is high, then in these patients, we should start diuretic. And if it refractory, we should do renal replacement therapy. Now, afterload optimization. So avoid hypoxia, hypercarbia, and acidosis to decrease pulmonary hypertension. Lung protective ventilation means tidal volume should not be more than 8 ml per kg. We can use pulmonary vasodilator. Inhalation of nitric oxide is the treatment of choice. We can use isoplastanol, pharmacodiasterase inhibitors. We can, like sildenafil, we can use in chronic setting. Endothelin receptor inhibitors like pusentan we can use. But keep in mind, when there is a failing left heart, like if wedge pressure is high and we give this vasodilator, it will lead to further failure of the left ventricle. So pulmonary wedge pressure should be less than 15 before giving these drugs. To manage RV contractility, we can use different inotrope, millinone, and dobutamine. But risk of hypertension is there. We can use norepinephrine, but we should avoid phenylephrine, which can increase pulmonary hypertension and systemic hypertension, systemic vascular resistance. So ultimately, will further increase the burden to the right ventricle as well as on the left heart. In refractory setting, we can take a mechanical support, right ventricular assisted device or ECMO, or we can go for transplant. So these are the basic right heart stent patterns like McConnell signs, RV diameters, RV size, RV length, RV diameter, flattening of interventricular septum, TAPSI if it is less than 16 mm. These are the basic right heart assessment, and in advance we see for TR jet velocity, S prime, E prime, and A prime velocity. We can see pulmonary acceleration time. Thank you.